శివ చెప్పేసి మాట్లాడుతున్నారు చెప్పేసి.
A very good evening to all of you. We welcome you on behalf of Andhra Pradesh Ophthalmic Society to the second webinar in the series of 15 lectures by our Subramaniam sir. And in this particular webinar, sir will be giving an introduction to ptosis and covering the classification and giving an overall overview. And I'm very happy to share that the first episode that was done by sir was very widely viewed by most of our members, and it is one of the well attended online webinars. Thank you, sir, for sparing your valuable time and getting into this teaching endeavor for all our members. Now I hand over the podium to you to continue further, sir.
Thank you, Dr. Madhu, for the nice words. And I'm happy that people are viewing it. Now, ptosis is a very common problem and which is very important both for the postgraduates as well as for the general ophthalmologist. So I thought I'll go a little more into the details, and I have split it into two talks. Today, I'll be talking mostly about the ptosis, its classification, and something about the diseases. In the next class, that's the next week, I'll be dealing with the evaluation of ptosis and the management strategies. I hope that should be useful to everyone. And for the postgraduates, I would like to say that one book that had a profound influence on me and on my career is a monogram written by Paul Beer on ptosis. That has changed my life, and probably if I'm an oculoplastic surgeon, it's because of the influence of the book on me. If possible, if you can get a hand onto that, please read it. It's one of the most outstanding books in the ophthalmic literature in oculoplasty. So let's go to the subject proper. And as I said earlier, in these talks, I am dealing with the important points, only important points. All the PGs are encouraged to read the textbooks because it is not possible to cover entire thing within 1 hour. With this, we'll go into the subject. What is ptosis? What is the normal position? The upper lid in straight gaze covers the upper 2 millimeters of the cornea. If it covers more than that, it's called ptosis. But before we make a diagnosis of ptosis, we have to exclude conditions which look like ptosis, but which are truly not ptosis. That's called, this group of conditions are clubbed under one heading, pseudoptosis. Ptosis bulbi, microphthalmos, inophthalmos. In these conditions, since the eyeball is small in size, it will not provide the support to the upper lid as a normal eye does. So, because of lack of support of the eyeball, the eyelid droops down. So, it is not actually the problem of the muscles of the eyelid, but the problem is lack of support. This is called pseudoptosis. Hypotropia. As we were talking in the previous class, the LPS follows the superior rectus normally. So if the patient has hypertropia, if the lid is down, the eyeball is down, the eyelid also will move downwards, and it looks like a ptosis as you can see here. Left eye looks to be ptotic. But when once the right eye, the fixing eye has been occluded, and the ptotic eye had been forced to fixate, that means the hypotropic eyeball goes up to take up fixation. The lid also goes up and the ptosis has disappeared. This is called pseudoptosis associated in case of hypertropia. Occasionally, people come with complaining of ptosis of one eye, whereas it is actually lid retraction that's there in the opposite eye. So here you look at the cases, an ophthalmic eye, a microphthalmus, and phthisis bulbis. These things do not provide support and can cause pseudoptosis. Here is again another case of pseudoptosis because of hypotropia. When the right eye, the normal eye is occluded, the left eye or the apparently ptotic eye has taken up fixation and the ptosis has disappeared. Here, this patient was supposed to be having ptosis in the left upper lid, but actually it is because of high unilateral myopia, axial myopia. This right eye is prominent, and that's why it was looking as ptotic. Similarly, this patient said that she came with the complaint of ptosis in the left upper lid. Actually, if you can see, there is a lid retraction on the right upper lid. You are almost able to see the limbus. The normal position as you are aware is it should cover 2 millimeters of the cornea. Below the limbus it should be. So that lid retraction, so the palpebral aperture on the right side is wider. They thought that it is normal and the patient thought that the left eye is ptotic, but is actually upper lid retraction of the right upper lid, a pseudoptosis. Ptosis can be classified as congenital and acquired. Congenital ptosis could be congenital simple ptosis or a congenital complicated ptosis. The congenital complicated ptosis could be a double elevator palsy or monoocular elevation defect or superior rectus weakness, which is the most common among the congenital complicated ptosis cases. The second is Marcus-Gunn ptosis or Synkinetic ptosis. Number 3 is Blepharophimosis syndrome. Number 4 is congenital third nerve paralysis. Coming to the acquired ptosis, there are 5 subgroups. It could be myogenic ptosis, which is the most common cause of acquired ptosis, followed by neurogenic ptosis, traumatic ptosis, mechanical ptosis due to increase in the weight of the lid, and miscellaneous conditions. How frequent? These are old figures. Congenital ptosis about 2,200, whereas acquired ptosis is just 675. So this happens mostly in India, where the congenital ptosis patients come to the doctor for a treatment, whereas the acquired ptosis, most of the elderly people, even though they have ptosis, they are not bothered much, and hence we find that acquired ptosis prevalence is less in India when compared to congenital ptosis. It is not actually prevalence is less, but the number of people who approach a doctor for alleviation of the symptom or ptosis is much less in acquired ptosis. So in the congenital ptosis, nearly 2/3 are congenital simple ptosis, 1,568, followed by congenital complicated ptosis, in which elevator palsy is the most common, 225 about. Next, Marcus-Gunn ptosis, 157, and a combination of Marcus-Gunn ptosis with elevator palsy, 146, almost as high or equal to the Marcus-Gunn ptosis, this number. Then Blepharophimosis syndrome, 84, and Turner palsy, just 50. Acquired ptosis, the most common is myogenic group, followed by neurogenic, and we had parasitic, especially myocysticercosis, presenting as ptosis in the endemic area. The prevalence has come down recently post-COVID, maybe because of better hygiene, and traumatic ptosis. How to know whether the ptosis is congenital or acquired? So ask the patient to look down. If there is a lid lag on down gauge on the ptotic side, as you can see in this boy, the left eye is ptotic, but on down gaze, the palpebral fissure appears a little wider on the left side when compared to the normal, that's the right side. This is congenital ptosis. Whereas if the palpebral aperture on the ptotic side in down gaze is smaller than the normal, as in these three conditions, it is acquired ptosis. Why this happens? We made a study of histopathological changes of LPS as a dissertation to one of my postgraduates. In congenital ptosis, some of the muscle is replaced with fibrovascular tissue. Here you can see these are the normal muscle bundles, whereas this is the fibrovascular tissue. So here, this is mostly fibrovascular tissue. As the muscle is replaced by fibrovascular tissue, the strength of the LPS is reduced, leading to ptosis. As you are aware, the fibrous tissue can neither contract nor relax. So on down gaze, since the fibrous tissue component does not relax, the lid will be at a higher level than the normal. So there will be a lid lag on down gauge in congenital ptosis. Whereas in acquired ptosis, there are two pathologies. Number one is fatty infiltration of the muscle. Number two, in aponeurotic ptosis mostly, the attachment to the tarsus is reduced, so that as that LPS moves, most of the fibers move away from the tarsus and its hold on the tarsus is minimized, there will be ptosis. Since the muscle doesn't have any fibrovascular tissue, as in case of a congenital ptosis, the lid relaxes in down gaze also, and hence the width of the palpebral aperture in down gaze is much less than the normal side. Now coming to the individual ptosis scenarios, congenital simple ptosis, this is a condition in which there is no other associated ocular abnormality except ptosis. And this is the most common type of congenital ptosis. Some books describe that it is familial. I have seen a very few families where the congenital ptosis has run in the family, but most often, more than 95 to 98%, there's no familial history in my experience. Congenital ptosis could be unilateral or bilateral, can involve either gender, and when it is bilateral, it could be symmetrical or asymmetrical. Levator function is usually poor to fair. Very rarely we see a good levator function in case of congenital ptosis. Here is a patient with a congenital simple ptosis. With severe ptosis, you are not able to see the light reflex. You can see that eyebrow is raised and there is no lid crease. This is because LPS action is poor. Only in those cases of congenital ptosis where the LPS action is poor, there will not be lid crease. Here you can see a child with a bilateral congenital ptosis. Where the LPS action is fair, you can see the lid crease. So absence of lid crease does not mean that it is always a case of congenital ptosis. Absence of lid decrease means that the LPS action is poor. That's all. Coming to the congenital complicated ptosis, there are 4 types. Number 1 is monocular elevation defect or double elevator palsy or superior rectus weakness. Number 2, synkinetic ptosis or Marcus gun ptosis. Number 3, a combination of double elevator palsy with synkinesis, that's DEP plus Marcus gun ptosis. Number 4, Blepharophimosis syndrome. Number 5, congenital terminal paralysis. Monocular elevation defect is the most common type of congenital complicated ptosis. This is because there is a close association between LPS and superior rectus, as you are aware in the anatomy. So sometimes what happens is the weakness of LPS may extend to the superior rectus, or embryologically as it's developing as a mass, both may be weak. One thing you have to remember is that there is a significant association between superior rectus weakness and synkinetic ptosis. This is very important because if you see a patient with superior rectus weakness, carefully, very carefully look for synkinetic movements and vice versa. Sometimes the synkinetic movement may be a couple of millimeters and the patient may not be aware. And if you do not document it and inform the patient about that, and if you do a surgery and post-surgery, they look at the eye closely and find the synkinetic movement, they may attribute it to your surgery. So, even in the exams, if you miss it, you may be losing the exam. So, remember that there's a very close association between synkinesis and superior rectus weakness. Bell's phenomenon is poor to absent depending on how bad the superior rectus is affected, and it requires surgery to restore the Bell's phenomenon before correcting ptosis, lest it can cause exposure keratopathy. This side I'm missing the last slide. Okay. So here is a patient with a congenital severe ptosis that you can see in the right upper lid, congenital severe ptosis. And here you can see that when the patient is looking up, the left eye is moving up, but the right eye has come to the primary position and stop. So this is the congenital simple ptosis with the double elevator palsy, or the other terms used are monocular elevation defect. And this is after correcting the hypotropia, restoring Bell's. She underwent a brow suspension surgery, and that's how she's looking after the surgery. DEP, that's double elevator palsy, is associated with pseudoptosis. That's what, as I have already told you earlier, nearly in 20% of cases. He is the patient with ptosis left eye with hypotropia. And as you can see, elevation is defective here in the left eye. But once the right eye is occluded and left eye is forced to take a fixation, the ptosis has disappeared. So in these situations, you have to get the hypotropia corrected, and also we have to get the Bell's phenomenon restored. Then only we think of doing surgery for the ptosis. So the treatment plan in DEP is, first we have to do a force reduction test. Remember that whenever the motility is restricted, it can be grossly because of 2 mechanisms. Number 1, either paralysis or weakness of the muscle. Number 2, a fibrosis or restrictive pathology of its opponent. So you do a force reduction test, try to hold the 6 o'clock limb and push it up. If the force reduction test is positive, that means inferior rectus muscle is tight and we would like to do a inferior rectus recession. If the force reduction test is negative, that means inferior rectus is relaxing. We do a NAPS procedure where we transpose the insertions of the lateral rectus and medial rectus on either side of the superior rectus insertion so that the superior rectus gets strengthened and then Bell's phenomenon is restored. Later, once Bell's phenomenon is restored, ptosis correction can be performed. Synkinetic ptosis or Marcus gun ptosis is the second common variety of congenital complicated ptosis. Here, abnormal synkinetic movements between the upper lid and muscles of mastication occur due to abnormal congenital connection between the trigeminal nerve that supplies the muscles of mastication and the superior division of oculomotor nerve that supplies the levator palpebrae superioris. So whenever the patient opens the mouth, moves the jaw to horizontally to opposite side, because of the innervation that it is getting simultaneously as the muscles of mastication are working, the lid moves up. So the patient may complain that when I am chewing, when I am eating, my lid flutters. So there is a close association between Marcus gun ptosis and superior rectus weakness or congenital ptosis with double elevator palsy. Almost, in my experience, it's about almost 50%. Here you can see this child with severe congenital ptosis on the right side. When the jaw is open, you can see that the lid has gone up almost to the normal position. And here also, I would like to show you that when he is looking up, the right eye is not going up. So this is a case of double elevator palsy associated with Marcus gun ptosis, a synkinetic ptosis. Here also, an elderly patient with a ptosis in the left eye. Now you can see as the patient opens the mouth, there is a lid retraction, and you can see that the hypotropia of the left eye and double elevator palsy. Under case of congenital DEP with synkinetic ptosis, normally we don't see the patient at this age, but just looking at the patient's age, don't come to the conclusion that it is a acquired ptosis. It could still be congenital ptosis, and where the patient is interested for a surgery at a later date for whatever is the reason. So in every case of DEP or in every case of Marcus gun ptosis, look carefully for the association with the other condition and document it. It's very, very important for your proper documentation and also for your examination. Inverse Marcus gun ptosis is very, very rare. I have seen only probably 3 or 4 cases where the lid closes on opening the mouth. It's congenital. More commonly, what we see is a similar synkinesis occurs. That means the lid closes when the patient opens the mouth. In Marin-Amath syndrome, it is acquired, not congenital. This is due to misdirection or aberrant regeneration of facial nerve branches after facial nerve palsy or injury to the facial nerve. As it is regenerating, there will be aberrant connection. So whenever the patient opens the mouth, the lid will come down. How do you treat Marcus gun ptosis? What's the treatment plan? It depends on the amount of synkinesis. If synkinesis is very mild, a couple of millimeters or less, patient is not bothered. We ignore the synkinesis and treat it as a simple case of congenital ptosis and correctosis. But if the synkinesis is significant, what we have to do is we have to do a levator excision so that you are excising the levator, which takes care of the synkinesis. And once the levator has been removed, now the LPS action has become zero. So we have to elevate the lid using a brow suspension technique. Blepharophimosis syndrome. In this particular type of ptosis, there is a narrowing of both horizontal and vertical dimension of palpebral aperture. In other cases of ptosis, there is a narrowing only of the vertical meridian. The horizontal width of the palpebral aperture is normal. But in blepharophimosis syndrome, both horizontal and vertical are reduced. It is mostly autosomal dominant trait, but about 10% are sporadic. It presents with severe bilateral ptosis, telecanthus, that is increase in the inner intercanthal distance, and epicanthus inversus. So with these things, it presents. Here you can see two children with blepharophimosis syndrome that you can see here, along with the parents. Here, this father underwent surgery previously. You can see these scars. And the blepharophimosis is not very bad. But if you see the inner intercanthal distance is increased, that is called telecanthus, you may be able to see a small fold that is called the epicanthal inversus. The horizontal width is reduced. The vertical height is also reduced so that the palpebral aperture becomes very small and narrow. That is phimosis, blepharophimosis syndrome. Here you can see the son and the father having BPS and compensated head posture that you can see in this child as well as the father. Running as an autosomal dominant in both the cases. Here is another case of blepharophimosis syndrome. You can see how narrow is the horizontal width and how short is the vertical width, and a huge telecanthus, inner intercanthal distance increase, and you can see epicanthus inversus very clearly, a case of blepharophimosis syndrome. Here, in the evaluation, we measure the inner intercanthal distance, that's the telecanthus, interpupillary distance. We measure the amount of ptosis, that's the vertical diameter, and also horizontal. And there are calculations that we do, and we usually do the surgery in 2 stages. That we come to in the next class, how we plan it out. Congenital Turner palsy is very, very rare. Here you can see a child with ptosis in the right upper lid. You can see that this eyeball is not adducting when the patient is looking to the left. And also the eyeball is not going up when the patient is looking straight. Right. And here the eyeball has abducted position. It's in divergent squint, showing that the lateral rectus is doing well. This is a case of congenital Turner paralysis, very rare. Now coming to the classification of ptosis, acquired ptosis, it could be myogenic, which is the most common, followed by neurogenic, traumatic, mechanical, and miscellaneous. Myogenic ptosis could be involutional or aponeurotic ptosis. Next is Myasthenia gravis. These are very common, these two, followed by CPEO or chronic progressive external ophthalmoplegia. Then it could be a myocytic, parasitic like a myocysticercosis and myotonia. Aponeurotic ptosis clinical features, if you look at, The ptosis is usually very, very severe. And you can see that there is a very gross ptosis in the left side and a mild ptosis in the right side. The levator function is very good most often. Then why there is severe ptosis with a good levator function? This is because the hold of the muscle on the tarsus is lost. It's only few fibers that hold or anchored to the tarsus. Most of the fibers have receded back, and so its action is good, but it cannot hold it. There's something like if I have to move your hand, if I hold your hand and move it, it is easy for me. But if I have to hold with a finger, my hold is only just a little bit of the finger. It will be very difficult to lift your hand. Similarly, when there are only few fibers which are attached to the tarsus, and most of the fibers have detached and receded back, they, in spite of having a good action, since the hold is not good enough, you are not able to lift the lid up continuously, and there is severe ptosis. There could be high lid crease, multiple lid creases. The lid is thin because the LPS is receding back, and there could be deep superior sulcus as you see here. Multiple lid creases here as you can see on both sides. And ptosis is worse on down gaze. Here, when the patient is looking down, you can see that entire lid is closed almost. And the patients sometimes complain that they are not able to do near work because the eyelid has been shut while looking down due to the severe ptosis. Occasionally, there could be diurnal variation, and it is worse towards the end of the day, like Myasthenia gravis. And Herring's is positive. Here you look, compare these first and third pictures. Is severe ptosis obstructing the pupil. When you raise the upper lid, what happens is when the pupil is obstructed, there is extra innervation to lift the lid, and extra innervation goes to the opposite lid, and the lid goes up to some extent. When once you lift the lid and the brain knows that the pupil is uncovered, there is no need for extra innervation. This person is able to see clearly with the ptotic eye what happens. The norm which the lid on the other side droops down, you can see. Right, this you look for, you have to look for, because if you do surgery on one side, because of herrings, the other lid may droop down. Inform this to the patient and attendants, document it, and preferably do bilateral surgery simultaneously. Since it's an age change, senile change, it could be associated with other senile changes. You can see, for example, this patient had a bilateral ptosis, involutional, had a bit of fat prolapse, and had a involutional ectropion here also. So it could be associated with involutional ectropion, could be associated with the involutional ectropion, could be associated with brow ptosis as you see here. So it could be associated with other senile changes. Myasthenia gravis. It could be an ocular myasthenia involving only the eye muscles, or it could be a part of a generalized myasthenia. It's an autoimmune disease targeting the acetylcholine receptors at the myoneural junctions, so that the transmission at the neuromuscular junction is affected. Thymus has a role in some patients because normally thymus comes down in size and becomes smaller and smaller as a person is growing in age. But in some of the patients with myasthenia, the thymus is much bigger in size, and rarely, some, as you are aware, thymus may be having a tumor, thymoma, which could be associated with myasthenia gravis. Antibodies against acetylcholine receptors are usually produced, and that can interfere with the normal neuromuscular transmission, so that most of these receptors are affected, leaving very few, so that muscle becomes weak and easily it gets fatigued. Myasthenia gravis is a common cause of acquired ptosis. Both genders are affected. Females usually at a younger age, less than 40 years of age, and males usually at an older age, more than 60 years, are more commonly affected. Can involve children also, that's called the congenital myasthenia. Incidence is 4 to 30 patients per million per year, and the prevalence is 150 to 200 patients per million. So myasthenia is fairly common, and we'll be seeing lots of acquired ptosis patients due to myasthenia. Most patients, and one more thing I would like to tell is that normally in case of thyroid associated orbitopathy, the common finding is that the lid is retracted. Lid retraction is the most common finding. But if you see a patient of myasthenia, TAO, thyroid associated orbitopathy, presenting with ptosis, suspect myasthenia, because myasthenia can be associated with thyroid associated orbitopathy. Most patients have autoantibodies against acetylcholine receptors. Some have antibodies against muscle-specific kinase, MuSK antibodies. Rarely the patients can be seronegative. What are the clinical manifestations? Ptosis. The ptosis could be unilateral or could be bilateral. If it is bilateral, it could be asymmetrical, and rarely it could be symmetrical also. So, the most common presentation is ptosis. They have fatigue is another important complex symptom for them. And this ptosis, there is a diurnal variation, because the normal position of the lid when we are looking straight is when the lid is covering 2 millimeters of the cornea, is because the levator palpebrae superioris is contracting with its normal tone. When the LPS has relaxed, the lid will come down. So when you are looking normally, always your LPS is contracting. So it's always continuously working. And because of the fatigue that occurs, there will be diurnal variations. In other words, when the patient wakes up, since there is enough rest during the night because of sleep, the ptosis is relieved, and the ptosis is less obvious, or there may not be ptosis. But by the evening, due to the continuous contraction of the LPS, which is going into fatigue, the droop increases, ptosis gets worse. So diurnal variations are very, very important symptom of myasthenia gravis. If it involves the motility, extraocular muscles, there will be diplopia. Very rarely there could be fleeting ptosis. That means there could be ptosis of the right upper lid, then automatically it may disappear. After several months, the ptosis may come back, or after several months, the ptosis may involve the other eye. That means right eye for some months disappears. After some months, left eye disappears. Thus, it can change. This fleeting nature can be in myasthenia gravis. So the clinical tests that we do are fatigue test. In fatigue test, ask the patient to keep his head in the primary position, take a torchlight and lift it up, and ask the patient to look at the torchlight. How long? For 2 to 3 minutes. Because the LPS is forced to contract to lift the lid up, and fatigue sets in myasthenia gravis, slowly the lid droops down. That is called fatigue test positive. Coggan's twitch. What is Coggan's twitch? Again, make the patient sit in the straight primary position. Put a torch and level with the patient. Ask the patient to follow the torch and then slowly lift it up and suddenly stop. Normally, when the light stops, our eyes will stop there. But in myasthenia, even after stopping the torchlight, the eyeball goes up, the eyelid goes up a little for a millimeter or two and then comes down. That is called Kogan's twitch, which is something like this. Third is ice pack test. It's a very simple bedside test, or OPD test, outpatient test, and it is 90 to 95% specific. So the simplest test for me to exclude myasthenia is ice pack test. Here what you do? Measure the amount of ptosis pre-ice pack test. Then keep an ice pack on the closed eyelid for 2 to 5 minutes. Normally for the lid, it's 2 minutes. If the extraocular muscles are also involved, 5 minutes. After the time, you ask him to remove it, open the eyes, and you see if there is any improvement. An improvement in ptosis by 2 millimeters or more is supposed to be positive. In other words, if the MRD1 is 0 millimeters, after the test, it becomes 2 millimeters, ice pack test is positive. But remember that it will not last for a long period. It comes back within a minute or two. Meanwhile, you have to document it. Here is myasthenia gravis. Diurnal variations, most common is myasthenia gravis. But as I said earlier, it could also be seen in involutional ptosis. But the reasons are different. Here is the patient, young girl with no ptosis practical in the right upper lid in the morning. In the evening, you can see that the lid has come down. There is ptosis, probably obstructing the pupil, leading to increased innervation to lift the lid and uncover the pupil so that the upper lid in the right eye gets retracted. This is the hearings that is taking place. Increased innervation to the ptotic lid is going to the opposite LPS also, synergistic muscle. This is the fatigue test. You can see that this patient is looking at the torchlight. Within 2 minutes, the lid has come down and the left lid and ptosis has become worse. This is the fatigue test in case of myasthenia gravis. This is the ice pack test. You can see that this young girl has again ptosis, bilateral, asymmetrical, more looks in the left eye. And now this is, I did it in my clinic. I call it as a sprite test. Don't tell it in the exams, but you can do it in the exam, in your clinic also. A cool drink bottle, which is, you can keep it, you substitute it for an ice pack. On the closed lid, it is kept for 2 minutes, and post lifting that cool drink, you can see that the ptosis has been totally disappeared and there is a good improvement in the lid. This is ice pack test positive. This is a case of ice pack test in this patient. You can see that this patient had severe bilateral ptosis and the eyeball is not at all moving in any direction, as you can see here. And we did the ice pack, and post ice pack, you can see that light reflex, you can see the eyelid is above the light reflex, whereas here you are not able to see the light reflex. So that it is showing more than 3 millimeters or of elevation or improvement post ice pack. So ice pack test is positive. So coming to the diagnosis, it is by clinical symptoms and signs. Number two, so diurnal acquired ptosis, diurnal variations, and fatigue test positive, Cogan's twitch, then ice pack test positive. You are most probably you are looking at a patient of myasthenia gravis. Penicillin test or hydrophonium test, we used to do it about 3 decades back. Now I hardly do it nowadays because whatever the result you get in penicillin test, you get it in ice pack test. In case of penicillin test or hydrophonium test, we load 10 mg of penicillin, and in another syringe we have 1 cc of atropine. Then intravenous injection of 2 milligrams of penicillin is given. Wait for 30 seconds because sometimes the patients can have very drastic reactions like palpitations, vomitings, and others, in which situation we give atropine to nullify this parasympathetic drug and its actions. If there are no reactions, you give the other 8 mg and wait for a minute or two. Within a minute or two, if there is improvement, the ptosis disappears, the extraocular movements are restored, then it is positive. Once we used to do these tests 30, 40 years back regularly, but once the ISPAC test has come and it has become very popular, it has become more popular. The advantage with ISPAC test is penicillin test has to be done in the theater. There are chances of side effects and sometimes which could be very bad. Whereas ISPAC test is very simple, no side effects, except for the fact that some patients, a few patients, will complain that it's very cold and may not be able to tolerate the cool temperature. Other than that, there are no side effects. Normally, what I do is when once ISPAC test is positive, I don't go for other investigations because when I make a diagnosis of myasthenia gravis, I will refer the patient to a neurologist for further investigations and management. The investigations the neurologist does can be the most important is single fiber electromyography, which is very, very sensitive. Or you can do blood tests like acetylcholine receptor antibodies, anti-musk antibodies, and other things. And some people may penicillin test and they make the diagnosis. And if necessary, they may ask for a CT scan of the chest to exclude thymoma. And then they start the treatment. The treatment could be simply tablets, or it could be steroids, or it could be plasmapheresis and other and immune suppression drugs. And the treatment is a big chapter. And that's why I don't deal with the treatment. My role ends with the diagnosis, and I refer the patient to a neurologist. Then another important acquired ptosis is chronic progressive external ophthalmoplegia or CPEO. As the name suggests, this is a very chronic disease which is slowly progressive, usually over a period of 1 to 2 decades or more. And it involves all the extraocular muscles only. That is why external ophthalmoplegia. The intrinsic eye muscles are not involved, they are spared. That means the pupil is not involved, pupil is brisk, and ciliary muscle is not involved, accommodation is normal, and there is no problem with hearing. This is a bilateral symmetrical ptosis with the limitation of ocular movements in all directions. In all directions, the movements are stopped. Whereas in the case of myasthenia, it could be few muscles. And sometimes you cannot neurologically attribute. For example, a ptosis with limitation of abduction. You can't neurologically say where is the level of lesion, right? So in all such atypical presentations, think of myasthenia. Whereas in CPO, it's a symmetrical bilateral ptosis with slow chronic progression and a limitation of ocular movements in all directions, and the pupil being spared, pupil is normal in size, risks and reacting very briskly, and accommodation is known. It's usually autosomal recessive in transmission, and some can be autosomal dominance depending upon the mitochondrial involvement. There is no diurnal variation, unlike myasthenia gravis. The types of CPO are three types clinically: ocular myopathy, oculopharyngeal syndrome, Kearns-Sayre syndrome. These are the three types of CPO. In ocular myopathy, it's only chronic progressive bilateral external ophthalmoplegia, usually in children, or the people younger in age, around 20 to 30 years. Most of the patients are less than 30 years of age. And this patient, as you can see, this young girl, there's a bilateral ptosis. I am asking her to look at, absolutely there is no movement of both the eyes. Motility is restricted in all directions, both horizontal and vertical, as you can see, and eye SPAC test is negative. So, for completion's sake, for every case of acquired ptosis, you please do eye SPAC test and say that eye SPAC test is negative to make sure that you have excluded myasthenia gravis, because the treatment depends totally when it is myasthenia and other conditions. This is ocular myopathy. This progresses. And what we do here? Here we'll wait until the pupils are really obstructed and the patient is not able to see. We'll do a brow suspension, minimal, so that the pupils are uncovered, or a mild levator resection. The advantage of brow suspension is, since the motility is restricted and over a period of time, the pupils are, the eyeballs are getting fixed without any movement. There won't be any Bell's phenomenon in future. And so they are prone for exposure keratopathy. So the correction should be minimal. With a brow suspension, if you are using a silicone, if necessary, remove the silicone sling and undo the ptosis correction. That's the advantage. Coming to the oculopharyngeal syndrome, which is very, very rare and progressive, it's an autosomal dominant inheritance. A few thousand cases have been reported only in the literature. It is common in Bukharan Jews, limited to certain families because of their autosomal dominant inheritance. Similarly, French Canadians in Quebec. It involves the muscles of the eye and also throat, so that there is difficulty in swallowing, and then some people difficulty even in speech. And it can also involve weakness in the muscles of shoulders and hips. This is oculopharyngeal syndrome. I am yet to see a case, and as I said, this is limited to certain families in those two countries, Israel and Canada. Kearns-Sayre syndrome. Here again, you see a bilateral ptosis, as you see, with impaired extraocular movements, naturally, as in the case of CPEO. You can see this girl has elevated brows because she is using all these to lift the lids. So there are three important symptoms in Kearns-Sayre syndrome. That is bilateral ptosis with impaired extraocular movement, atypical retinitis pigmentosa, and conduction defects in the heart. Here you can see a scar. This is because of the surgery that was done to implant a pacemaker. So this young patient is a patient of Kearns-Sayre syndrome. These are serious conditions. Sometimes it could be associated with cerebellar ataxia, neurosensory hearing defects bilateral. There could be high CSF protein levels and can have renal problems. And unfortunately, the life expectancy is around 40 years only. Parasitic or myocysticercosis. There was a period of about 10-15 years window period in my career where we have seen lots of cases of cysticercosis presenting with ptosis, presenting with myositis component, myocysticercosis of the orbit and proptosis. Now the incidence has come down fairly much. It usually involves younger individuals in endemic areas who take raw food, uncooked food, and salad eaters. It could be acute or subacute in onset with pain and discomfort. The doses could be mild to severe, and in about 65% of patients, anti-cysticercosis antibodies are seen. CT scan of orbit shows enlarged levator palpebrae superioris, superior rectus complex with a cyst having a scoliosis. Here is a patient, young woman with mild ptosis. The CT scan shows enlarged superior rectus with a cyst and scoliosis, and this is treated medically with albendazole and visolone, that's prednisolone. Albendazole at a dose of 15 milligrams per kg body weight and visolone at a dose of 1 to 2 milligrams per kg body weight, depending on the inflammation. Since the inflammation is very minimal here, I started here prednisolone 1 milligram per kg body weight, and 2 weeks down the road, you can see the improvement in the doses and normal elevation, which was a little bit involved at the time of presentation. Here is another young girl with severe ptosis, edema, inflammation, pain, and the CT shows enlarged LPS SR complex with a cyst and the scoliosis. This white spot is the scoliosis that you can see here. Put here again on albendazole plus visolone, that's prednisolone. Prednisolone at a dose of 2 milligrams per kg body weight. So this is the patient before treatment, 2 weeks after the treatment, where most of the edema, everything has subsided and she has recovered very well. Myotonia is a very rare condition associated with genetic mutations. There could be weakness and wasting of facial muscles, could be associated with cardiomyopathy and cataracts. To be honest with you, I'm yet to see a case of myotonia. It's not very common. Neurogenic ptosis, it could be because of Turner palsy or a Horner syndrome. Turner palsy could be acute or chronic in presentation. Whenever the presentation is acute, think of vascular causes like infarctions, thrombosis, hemorrhages, as in hypertension, diabetes, or aneurysms which are leaking and burst. Chronic, you suspect intracranial space occupying lesions. The Turner palsy, ptosis is first to occur and first to recover. So the symptom of diplopia depends on the position of the eyelid. In the early stage where the ptosis covers the entire lid, eyeball, there is no diplopia. But as it starts recovering and the pupil is uncovered, patients then will have diplopia. It is associated with the divergent squint due to the unopposed action of the lateral rectus, since the medial rectus is involved in the Turner paralysis. Look for the action of superior oblique muscle, intorsion on down gaze, which occurs, you can't look for the elevation or the vertical action of depression of superior oblique, because superior oblique is a depressor only when the eyeball is in adducted position. But since the eyeball is abducted due to the action of lateral rectus, you cannot look at the depression. You have to look at the intorsion, and it is usually present. Examine the pupil. If the pupil is involved, there can be a serious problem like a intracranial space occupying lesion. Fundus examination is mandatory, and ask for a CT brain if needed. It is a patient with severe ptosis, and lift the lid, you can see there is a divergent squint. The eyeball has gone totally abducted because of the unopposed action of the lateral rectus muscle. Intorsion is okay. If you look careful, the pupil is dilated. So we asked for a CT scan. What does it show? It shows a huge supracellular, this is the cellular, supracellular meningioma. Not our cup of tea. So whenever there is acquired ptosis with a Turner palsy, pupil is dilated, unexplained ptosis, please ask for a CT scan. Imaging is very, very important. There's a Horner syndrome is because of damage to sympathetic nerve pathway, presents with ptosis, which is mild, about 2 millimeters. Meiosis, because the dilator is affected. Anhidrosis of face on the affected side is a very rare condition. Traumatic ptosis could be because of direct trauma to the levator palpebrae superioris, or because of traumatic Turner palsy, or traumatic inophthalmos in fractures of the orbit. With a direct big trauma involving all the layers of the eyelids and the LPS, it can lead to ptosis. And here is a patient with a traumatic ptosis with fracture orbits and inophthalmos. Mechanical ptosis is due to increase in the weight of the lid, as in edema of the lids, tumors of the lid, trachoma stage 2, multiple lesions, and all that. Because of increase in the weight, it leads to ptosis. As you can see here, he is a case of Meep cell carcinoma with ptosis, another case of Meep cell carcinoma with complete ptosis, another case of squamous cell carcinoma. Sorry, it's also a Meep cell carcinoma with severe ptosis, is a severe edema of the lids with inflammation leading to ptosis covering half the pupil. These are all the cases of mechanical ptosis. It is a case of a capillary hemangioma in a small child born with a severe capillary hemangioma leading to ptosis and its involvement into the orbit. Treated with, we'll come to that in the next treatment part, will come into the next class. So the take-home messages are, ptosis is fairly common. It's very important in your daily practice also. Congenital simple ptosis is the most common type among congenital ptosis. Close association between ptosis with DEP and Marcus-Gunn ptosis is present. You have to look for them. Some types of ptosis like Blepharophimosis syndrome, chronic progressive external ophthalmoplegia have genetic predisposition. Myogenic ptosis is the most common type of acquired ptosis. Aponeurotic ptosis is the most common type of myogenic ptosis. Ice pack test is the simplest bedside test to diagnose myasthenia. Look for the involvement of pupil in neurogenic ptosis, and if necessary, order for a CT scan. Fundus exam is very, very important. Thank you all for your time and patience. Thank you.
Thank you, sir. Thank you so much. I think you have wonderfully covered all the possible causes for ptosis, and especially thanks for those Atlas grade images that you have showed us. Beautiful images depicting the different kinds of ptosis, sir. I think in the faculty link we have Jagannath sir and Swaroop Rani ma'am. Ma'am, if you want to add anything. Jagannath sir. Okay. Thank you, sir.
Thank you.
So we'll meet again next week, elaborating on the evaluation and management of ptosis. That would be the topic, sir, next week.
Yes, yes.
Yeah. Thank you, sir. Thank you so much.
Thank
Yeah.
you so much.
Good night, sir. Good
Thank you
night.
so much. Good night. So just close it.